Hello, these are flipped notes 8-7 on the treatment of psychological disorders in the clinical psychology unit. Let's get right to it. So, the history of treatment is not so great from early on. Insane treatment was often maltreatment. Many irrational views led to that. Patients were subjected to some strange, debilitating, and downright dangerous treatments, lobotomies, boring holes in the skull, things that we don't do anymore. By the 1800s, things had improved some. In France, Dr. Philippe Pinel, and in America, Dorothea Dix were both known for their efforts for the humane treatment of the mentally ill or the mentally sick. Our focus in this section, though, is on therapy and other methods of treatment. When we say psychotherapy, that's just a general term for any kind of emotionally charged interaction between a trained therapist and a mental patient, and that can happen in both an inpatient or an outpatient facility. Biomedical therapy is when we're using drugs or other procedures that act on the patient's nervous system, and that'll be in our next section of notes. And then an eclectic approach is just the idea of using multiple different methods to help in the treatment of a client. There are four main categories of psychological treatments that we'll look at: psychoanalytical, humanistic, behavioral, and cognitive. And based on things we've talked about all year long, you can probably predict what a lot of those therapies are like based on just what those different perspectives view about human behavior. The first formal psychotherapy was psychoanalysis, which we've talked about a little bit before when we talked about Sigmund Freud and the psychoanalytic perspective. There's Freud's famous couch, which is actually on display in a museum in London. Freud had initially used hypnosis as a method for psychoanalytic treatment, but he quickly realized that it was not very effective, and instead he moved on to what he called free association, where the patient would lie on a couch and just speak freely about whatever comes to mind. Well, Freud realized that patients would naturally edit their thoughts, they'd resist their feelings and their emotions, and they didn't really say exactly what was because they were anxious about what they had to say. He called this resistance. He said it was a normal part of psychoanalysis. But eventually, the patients would overcome resistance and they'd open up, they'd reveal their innermost feelings. And a lot of times, they would develop extreme emotions of either really positive feelings. He had lots of patients who he said would throw themselves at him, they'd fall in love with him. And even in modern treatment today, it's common for patients to become attracted to their therapist. And this is known as transference, that they're transferring feelings for somebody else onto the therapist or the doctor. Sometimes the feeling is the opposite with transference, and they feel very negative or angry feelings that are really from somebody else, but they're directed again onto the therapist. The criticisms of psychoanalysis, just like everything else of Freud's, that it can't really be proven or disproven. And in generally, psychoanalytic treatment takes a long time because you're just waiting for them to speak and to kind of get everything out. And that can be very expensive, which insurance companies don't really like having to pay for that many sessions. Today, the psychodynamic therapies follow in a lot of those Freudian techniques, especially the idea of probing the past, speaking, that type of talking, which we also call insight therapy, just the idea of talking. And talking will provide insight into a person's thoughts and feelings. Interpersonal psychotherapy today is a specific type of psychodynamic therapy that works with treating depression, and it doesn't really try to change the whole personality, but really looks at the past and how to focus on relief in the present. But they still use kind of the ideas of free association, try to interpret some dreams, and they look at transference as well. Our next category are the humanistic therapies based off of the theories of Abraham Maslow and humanism. And in these therapies, the goal is to boost self-fulfillment by helping people grow in their self-awareness and self-acceptance. So that often looks like person-centered therapy, or sometimes client-centered therapy, CCT, developed by Carl Rogers. And in that, their focus is that unconditional positive regard, that the therapist is really listening to the needs of the patient in a very accepting and non-judgmental way, and that'll help build their self-esteem. This active listening involves echoing and restating the client's thinking, acknowledging their expressed feelings, but really a lot of the echoing. So when a client says something like, I feel very anxious and I get upset easily when this person talks to me, and then they just echo it back. So you're saying that this person causes you to feel anxious when they talk to you. And then when you hear that as the client, you start to think, is that what I feel? Because you're hearing it back, and it allows you to help clarify your thinking. Behavior therapy is our next category. And with behavior therapy, they're applying different learning principles, trying to eliminate unwanted behaviors. So these are based off classical conditioning as well as operant conditioning principles, used commonly to treat phobias, sexual disorders, but any kind of behavior, obsessive behaviors that can benefit from altering the actual behavior. They don't delve too deeply into the past, and they're not looking for all kinds of inner causes. They just want to treat the actual behaviors. Two kind of techniques here. Both the types are of counter conditioning. With counter conditioning, they're trying to condition or create new responses to a stimuli that trigger the unwanted behaviors. They're trying to create a different response that will replace the old response. That can be done through exposure therapy, and we've got a couple types of exposure therapy, and aversive conditioning. Exposure therapy is also sometimes called flooding. And in this one, you expose the patient to what they're actually scared of. So you're directly exposing them to it. And through repeated exposures, the anxiety lessens because they habituate to it. And habituation is just the diminishing of the response with frequent exposures or frequent time around it. So the idea is that you're scared of snakes. You actually are confronted with an actual living snake. It's scary, but you survive it. And then you realize, okay, maybe it wasn't so bad. And then you do it again and you do it again. So continued exposure to what they're actually scared of. Somebody who's scared of the ocean, they're going to actually wade right out there into the water and be exposed to it. And they'll do this over and over again until they're not scared of it anymore. They habituate to it. Habituation, that new song you love isn't so great after the 500th time you hear it on the radio because you've habituated to it. Exposure therapy, as we said, is sometimes called flooding. Sometimes they don't do it in the real environment. Sometimes it's in a virtual environment instead. Astronauts here are training with virtual reality to face things that they might happen to come across in outer space because they can't actually do that in real life. Systematic desensitization is another type of counter conditioning and really a form of exposure therapy. And in this one, the person gradually faces different levels of what they are scared of, different levels of anxiety triggering stimuli. So they might start, if they're scared of spiders, with a picture of a spider, and then with a toy spider, and then a dead spider, and then a live spider that's in a container, and then eventually a live spider in their hand. They're systematically desensitizing to that anxiety triggering stimulus. The idea of systematic desensitization originally came from Mary Cover Jones, who is sometimes known as the mother of behavior therapy. She worked with John Watson, who we know for the Little Albert experiment. And it's kind of ironic because Little Albert was trained to fear something, while Mary Cover Jones taught them to not fear things. So it was kind of the opposite. So she taught this desensitization. Probably her most famous experiment was the Little Peter experiment, so contrasting Little Albert. And in this one, she taught a small boy to not be afraid of a rabbit through the use of pairing the rabbit with pleasant stimulus. That's Mary Cover Jones. Joseph Wolpe is also known for his efforts in systematic desensitization with the development of the anxiety stimulus hierarchy. So with this, the client is encouraged to kind of come up with a list of what is the most stressful to them and what is not so stressful, and they work through that in in this gradual building up to what they're most scared of. I put the example as public speaking, but I accidentally changed it to the spider example. But they're slowly exposed to each level. The other key thing is that they're going to pair a relaxing stimulus at the same time. So maybe you love Taylor Swift music and she's very calming to you. As you're going through the hierarchy, you would also be exposed to something pleasant. So there's a little bit of that classical conditioning there to help them remain calm. Aversive conditioning is our other type of counterconditioning, sometimes called aversion therapy. And in this one, the person associates an unpleasant state with an unwanted behavior. So, for example, to make somebody not like alcohol so much, they could put in this nausea-producing drug. They drink the wine or the alcohol, they feel sick, and then they no longer want to drink that alcoholic beverage. So they form a taste aversion, basically. This has been effective with treating people to help them stop smoking, nail biting, alcohol, drug dependency, different things. Sometimes it's difficult though because the person knows that's what's triggering the nausea, and they can kind of like mentally overcome that. They know that, well, I'm not really getting sick from the wine or the cigarettes. It's actually this other thing that's in there. So, but sometimes it does work. Our next type of behavior therapies are some operant conditioning techniques. And remember that B.F. Skinner was the one to teach us about operant conditioning, the ideas of rewards and punishment and schedules of reinforcement. In these techniques, they're using behavior modification to reward undesired behaviors. And sometimes they use punishment, but mostly they're just using a reward system. Specifically, applied behavior analysis, ABA, is a real up and coming technique that's used with autism or children who are autistic, and especially ones who are very withdrawn. And they reward them to try to kind of encourage them to participate in desired behaviors. A token economy is another specific type of operant conditioning in which patients exchange a token of something, or they earn something for a privilege. Sometimes this is used in treatment for eating disorders, where a patient might be in a room and they basically have nothing that they enjoy in the room. And when they eat a meal, maybe they get a magazine. They eat another meal, they get, time on the internet. But for each time they do something, they get that reward or that token to increase the likelihood of doing the behavior again. Our next category is cognitive therapy, and we know that cognitive is our fancy word for thinking. So in this therapy, people are changing their ways of thinking and acting to be more adaptive and more healthy. The goal is to control their thoughts and to work on self-talk. So, for example, before therapy, when somebody loses a job, their internal beliefs and thoughts are that they're worthless and they feel hopeless, and that can lead to depression. By redirecting those thoughts and changing their inner beliefs to, well, my boss is a jerk and I deserve something better. So they kind of change their perspective on it, and that may be less likely to cause depression. Aaron Beck is one of the first big names that we associate with cognitive therapy, and he suggested that, especially in depressed patients, the problem is with their thinking, that they have these cognitions such as, I can never be happy. And they need to change that in order for their depressed patients to recover, that yes, you can be happy. So a lot of self-talk. And that's usually done by gentle questioning. And they'll kind of say, you say you've never been happy, but what about, when you watch your favorite TV show? Do you feel happy in the moment there? What about when somebody sends you a text message to check on you? Do you at least feel happy at that moment? And they say, well, yeah, I guess I do. So see, you are capable of feeling happy. So it kind of starts with there, that changing that self-defeating thinking. Different types of cognitive therapies. Cognitive therapy in general, again, involves shifting that cognition, and then the behavioral changes will go with it. Rational emotive behavior therapy is a more specific type, and really it's still cognitive therapy, but this is what Albert Ellis called it. He was a bit eccentric, interesting person. But again, he said that a lot of the problems come from irrational thoughts. Therapy involves showing the patient their distorted thinking so they can eliminate it. So when you say, everybody hates me, Ellis would say, really? Everybody in the whole world hates you? These people in China who never met you, they hate you? And be like, well, okay, maybe not everybody, just a few people. So changing the rationality of their false beliefs. And then cognitive behavioral therapy combines both cognitive, changing their thoughts, and their behaviors. Stress inoculation training is a specific type of CBT that's used more commonly for PTSD. changing again those incorrect and negative thoughts, helping try to restructure their thinking. Group therapy is commonly used both at inpatient and outpatient facilities. Several people in the group, sometimes sessions are about 90 minutes. And a couple main reasons is one, you can help more people at a time. And in a field like psychology and psychiatry, where there's a huge shortage in professionals or in doctors for treatment, that's kind of what they have to resort to. And it's also more cost effective. The other reason is that sometimes it really helps in knowing that others have similar problems and hearing their stories, and that you're not the only one facing that. Group therapy is a general term. It could mean anything from like Alcoholics Anonymous, that may be led by somebody trained in the program, but not necessarily somebody who's specifically trained or has a degree in mental health. Or it could be formal group therapy that's led by an actual psychiatrist or psychologist. And then our last category is family therapy, which is a more specific type of group therapy, but it treats the family as a system. So, not just treating individuals, but the family as a whole. A lot of times I do different kinds of role playing and helping with building positive relationships and really trying to improve communication. All right, that's it for our section on treatment of psychological disorders.